key question that you have to ask, and the patient has to really be aware of, is are they a first time or are they a repeat offender?
Yeah.
Okay. And this is what we forget. So we keep thinking that the ankle sprain is about, it's the key thing to pick up is do you keep going over? Okay. And it's amazing how many people go over and don't even know it.
Yeah.
So if you said, let's go one joint up in the body. Okay. Yeah. If you said, I come down the stairs, my knee buckles and I fall down the stairs, you would go to A&E.
Yeah.
You wouldn't accept that.
Yeah.
Yet you can accept that your ankle buckles every 2 weeks, every 4 weeks, every 6 weeks.
And when we say buckles, it's that classic, you don't even have to go down a step, but you get the rolling over of the ankle and you sprain these ligaments on the outside.
And they're so loose now.
Yeah.
So the first thing is people think, well, what's happened to my ankle ligaments? So ankle ligaments are interesting because, as you know, they're not really working all the time. These are kind of like a fifth gear. They only kick in sometimes.
When they're really
needed. So most of the life we walk through, if you're walking around Sainsbury's, you're not going to sprain your ankle because it's a completely level surface. Yeah. But when you put your ankle in a slightly funny position, that's when you strain the ligament and that's when the ankle buckles. Yeah. Now, it is not normal to sprain your ankle.
Yeah.
I might say, fine, you might sprain if you're very athletic. Someone like yourself, Chris, strapping young man, still enjoys things. Not so young anymore, hiking, swimming, all those things you do.
Yeah.
You might strain your ankle, but even I'd expect, say, once every 6 years, once 7 years. I wouldn't expect you to do it once every 6 weeks.
No.
And the frequency, so then we come into the concept of ankle instability.
Yeah.
So there are many ways of looking at it. I love it because, when I examine my junior doctors, I always say to them, what's an unstable ankle? The easiest question you could ask them.
Right.
And they go on all the tangents. It's when this ligament must be done. I said, no, just what is an unstable ankle?
When the patient tells you that they
go
rolling
their ankle.
So instability
instability means your ankle goes over on uneven surfaces.
Yeah.
Okay, it doesn't go over on level surfaces.
Yeah.
Okay.
And we also find that, say at 15 years old, they were playing netball and they had a really big sprain. They're in agony. And say they're 24, because it often is in quite a young age group, isn't it? A very active population. And then say they sort of sprain it every 4 months, every 8 months. And you almost find that it, as you say, it becomes their normal. And actually with every ankle sprain, sometimes they recover quicker.
Yes.
Because their ligaments have gone. And there's not a latch, but the key thing is they're probably damaging their joint and probably not doing themselves any favours in the long term.
They become immune to it. I mean, they literally buckle their ankle completely, and then there's nothing left to hurt because the ligament's shot and gone. Yeah. So they walk down the street again. Yeah. But the problem is you bang your head, you fall over. I've had patients come see me with instability. They've fallen downstairs carrying the child because their ankle buckles. The child moves a bit funny, they buckle ankle. So it can be serious. But the problem is, and the reason we need to pick up on this group, the chronically unstable ankle is what we're talking basically about, is because the unstable ankle leads to arthritis of the ankle.
Yeah.
And ankle arthritis is invariably due to trauma, which is either a big fracture or it's repeated sprains.
Right.
Okay. Yeah. And that's what we want to protect because our joints are designed to work in a certain way. So putting it very simply, the ankle is not a hinge, but if you imagine it's going up and down, okay?
Yeah.
All right. Now, what happens if you start twisting it and buckling it, then you impale this corner of your articular surface in the joint.
On that talar dome.
And as you impale that corner, what happens is you start getting erosion and wear. You get damage. And so it is important to identify the unstable ankle. Now, once you've identified it, what do we do with it? You guys fix it. Most of you fix most of it.
Yeah, so from a physio point of view, we see lots of unstable ankles. So patients walk in saying they keep rolling over on their ankle. And the way I see it is you've got two types of stability around the ankles. You've got your mechanical stability and your functional. So mechanical refers to the bones, the ligaments, the things that hold it together. And most of these patients are compromised with their mechanical stability because their ligaments are torn, their tendons are weak or torn. And then you've got that functional side of it. So that's the strength of the muscles, the balance of the ankle, even it comes down to the speed that you recruit your tendons and muscles. Because what should happen? We're almost spraining our ankle all the time, aren't we?
Yes.
But it's the correction of the muscle, that functional stability, that corrects your foot without you even knowing it. And when you've got an instability or you haven't got that, then obviously your muscles and tendons don't come in quick enough, they're not reactive enough, they're not strong enough, and they don't correct the ankle, which means without you knowing it, you're going over on the ankle. So I think from a physio point of view, we do really well with these. And actually, if somebody is very compliant with their exercises, which is obviously a key thing, we think we can get them better. Absolutely. But sometimes it's gone too far, and often it's the patients that maybe should have been seen by somebody like yourself a little bit earlier, because essentially they're not going to resolve with physio, and we obviously refer you patients for this. But the thing I'm really starting to understand is, unfortunately, with arthritis of the ankle, it's a lot rarer. Now, if you have arthritis in your knee and particularly your hip, we can generally say that that knee replacements, hip replacements are pretty options. Decent, aren't they?
Whereas we haven't got great options for ankle arthritis.
So absolutely. By the time they come to you at 60, 50 and they've got an arthritic ankle, it's a bit late.
And there's not a great plan B. There are plan Bs, but they're not great plan Bs. Yeah. Absolutely. And what you said is very interesting. So people say, well, how do I know if the physio's worked?
Yeah.
So the exact thing the patient will say to you is they go, yeah, my ankle is still unstable, but I know how to stop it going over. Okay?
Right.
Because you've trained them.
Really slowly.
You've trained them. You've trained them. You've trained their muscle pathway, muscle memory to kick in quicker so they can correct it.
Yeah.
So the problems that happen is, number one is, that's great if there's a person who goes to the gym every week and he does 10 minutes of ankle exercises.
Yeah.
But what you end up finding with some of these is that they come 3-4 months down the line, they stop doing the exercises, ankle starts going over again.
Yeah.
And that's where we talk about then, where I get involved, to talk about maybe repairing the ankle ligaments. Okay?
Yeah. So tell us a little bit more about, I suppose, can you think of a case you've done in the last few weeks where you've repaired an ankle? Give us maybe a bit of background on how you got to that. Because obviously it does depend on whether maybe their ligaments are torn, but also they've got a tendon tear or they've got some synovitis, so some thickening of the tissues. Absolutely. And also then what do you do in surgery to actually repair these?
So the indication, so the first thing that we have to clarify, and this is very important to anyone hopefully listening today, is that they'll have an MRI scan and they'll say the MRI scan will always say the ATFL, or the lateral ligament of the ankle is a little bit torn, a bit more torn, a bit fibrosed.
Or missing,
ruptured, absent, completely ruptured. And then they'll come to me saying, well, why are you not doing something about this completely ruptured ATFL? And the answer is, it doesn't matter. Because the ATFL or the ankle ligament is different to the cruciate ligament in your knee. Okay? That's the one people commonly hear about, the other ligaments torn. The cruciate ligament. When that snaps, it ricochets to the other end of the knee. But the ATFL blends in with the capsule of your ankle. And because it blends in, even if it's damaged, even if it's a bit torn, even if it's completely false, it's still kind of there. All I'm worried about is, has it healed with enough tension?
Right.
Okay.
So how would you assess that?
Perfect. So that we assess clinically, both from the story. So they'll say that I go over a lot. Say, okay, I'm starting to worry about this guy's ligament. But we do a maneuver I'm going to examine called the anterior draw.
Okay,
or we test them on inversion. Okay. And you compare it. The great thing about ankles, we've got two. Okay. So we just compare it with the other side. You've got a control. Okay. Normal side thing. And if they're acutely sore, I can't assess that the first week. But else, if for 3 or 4 weeks when the swelling has come down, I can check this instability. And if the ankle is loose and there's too much play and they've done the rehab, then I'll say, okay, now let's talk about reconstructing the ligament.
Okay. I think that's really important because certainly we see lots of patients that, have an MRI and MRIs are really good, aren't they? Ultrasound's also really good because you can do some dynamic maneuvers, which we do quite a lot. And
ultrasound is more than enough for the ligament. Because actually it picks up exactly.
And tendons, it's really good at. So, but the key thing you've said there is it's not just about what those static images, look like. It's about how it feels and whether or not there's that laxity.
And that's where the assessment comes in.
And that needs to be done by somebody who sees
a lot. So you see it, you assess them, and then you say, well, what do we do now? So they say, well, I'm only go over when I play ball. You say, okay, fine, you can wear a brace. You won't go over in a brace. But if they're saying, no, I'm going over more often. Or I worry
I see lots of patients with the air cast braces, the Andy Murray.
Andy Murray brace, he wears too. But, probably habit rather than absolute need, maybe.
Superstitious about these things,
isn't it? But so you can brace it. But the thing is, if you keep buckling over. So I was one of the most famous cases I remember seeing. Well, one of those, you have a case that sticks in your head.
Yeah.
And I saw many years ago, I saw a lady who was referred, who played lacrosse for Team GB, okay?
Yeah.
And she would buckle her ankle every single day, okay?
Yeah.
And actually, by the time she came to me, there were arthritic changes in the ankle.
Right.
So she had a great team physio, okay? He did about 70 sessions of rehab, okay? She never buckled when she played. Okay, why? Because he's a zinc oxide.
So you can tape him up.
Tape her up. He'd tape up, she could play. Yeah. But she'd take the tape off for a shower after the game.
And she'd sprain
the ankle coming out the shower or the night out. She'd always sprain her ankle.
Yeah.
And the ankle is just too loose. Yeah. Now, ankle ligament reconstruction is the most successful ligament reconstruction in the human body.
And that's called
Brostrom. Yeah. Okay, so typically we've got Brostrom Gould repair. Okay.
Yeah.
So if we compare it from shoulder.
Yeah.
Don't even go there.
No.
Okay. Or ACL, which is a successful one. Yeah. But my God, it's an 18-month recovery, Chris.
Well, it takes time.
It takes time.
Yeah.
Ankle ligament, they come in with a ligament that's too wobbly. Hey, they come out with an ankle that's a bit stiffer. It's fine.
Yeah.
Job's done. Yeah. And it's an anatomical repair. By that, I mean we're not adding anything in.
No.
I'm just essentially using a suture in a clever way to take someone's ligament. So imagine this is a ligament. It's now loose. Yeah. We're basically rocking it up and tightening the ligament. Yeah. And that's what we're doing. We're basically finding their own ligaments. Yeah. That ATFL, which is a bit loose, a bit fibrosed, a bit scarred, tightening it up and smoothing.
I must say, I saw you do one of these and I was surprised how not easy it looked. I don't want to underplay, but compared to I've seen an ACL where there's a lot of drilling involved.
So you're finding some ligament that's too loose, you tighten it up.
Yeah. And I must say, from a physio point of view, once you've got over that initial swelling from the surgery and you've restored range, they are quite straightforward.
They're quite straightforward, and you can expect them to get back to competitive sports.
And in the research, my understanding is it is actually a 90% plus success rate.
It's
to get back to sport.
Oh, absolutely. And you will go back. You have to go back to your own sport. You know.
Yeah.
You have to go back to your own sport.
Yeah. That's the whole role of doing it.
That's the whole role of doing it. The aim is to get you back to exactly what you do.
And the risk is and I definitely have a group of patients, and I think I'm more aware now than when I was, say, 10, 15 years ago, that I'm not saying, as a physio, you try and improve things with physio, but what we found a lot of the time is that they would get better, but they're not actually back to what they want to do. No. So say they come to us because they want to get back to rugby, they're walking around fine and they play a bit of rugby, but they don't actually get back to that level. And you want them because our function is to get them back to where they expect to be. But I think if they are continuing to sprain,
it's absolutely.
Then you either give up the thing that's causing the sprain.
Yeah.
But if it keeps spraining when you're walking or going in the shower or going on a night out, then you've still got to consider it because of the damage it can cause to the joint.
Yeah.
So I think again, it's like we were talking about the Achilles rupture on the Achilles rupture podcast. It's having that understanding that although it's not it's not going to kill you or anything like that, it can cause you long-term problems. And by the time you've got those problems,
and it's a lot easier to fix than an Achilles tendon.
Yeah, that's
the thing.
Yeah.
It's actually an easy win.
Yeah.
Ankle's wobbly, ankle's not wobbly. There's no middle ground there.
Yeah.
You come in ankle's wobbly, come out ankle's not wobbly.
Yeah.
Ankle's confident.
Yeah.
And remember, yes, we can manage that with continual rehab and them doing the exercise. But if their ankle ligament's been put back to like it was, even if they don't complete the rehab or they never do it again.
So what about that client that comes in, they say that they've got an MRI that shows the ATFL torn, the CFL's torn, they've got some peroneal tendon problems, and they've got pain, but they don't have the instability giving way.
Fantastic.
Because we see a lot of that. Those aren't the ones I'm referring off to a surgeon.
No. So and that's great. So what you're describing there is a painful ankle that is a sprain that still hurts.
Yeah.
But it's not unstable.
Yeah.
So the commonest cause of that, Chris, is impingement. Okay.
Right.
And we talk about those of we know about other joints that impinge like the shoulder, but basically what happens is if you imagine that your ATFL or your lateral ligament is a horizontal ligament and it just runs there.
Yeah.
And it's a very thin ligament, not much thicker than the credit card.
A normal one's about 2 or 3 mil.
It's shocking. It's like a piece. It's like a credit card. It's like a good business card, like my firm ITSM business card.
Like your Amex Black or Platinum or your Coots Bank or
something like that. Yeah. So it's like a nice thick business card, but it's there. And what happens is it's so fine and so elegant. But when you damage it,
because it's so fine, and when you move the ankle, it just doesn't get in the way.
But when you damage it, it gets a bit rougher. The body reacts to it. You get what we call synovitis.
Yeah. And on ultrasound, I can tell you that tissue goes from like that 2 mils to about 5 or 6 mils.
But the ankle is a really small space.
In the way.
It's not like your knee or your shoulder got loads of space.
Yeah.
Okay, it's a tiny joint. So what happens is you bend the ankle up and down, the tissue catches.
Yeah.
So
and that's the synovium, isn't it? So it's actually very pain sensitive.
Pain sensitive. So the easiest way of managing that is what you do, which is just inject a little bit of cortisone.
Yeah.
Cortisone will
under ultrasound guidance.
Under ultrasound guidance or freehand if it's hand, that's fine. But of course,
I know it's when I would.
Freehand, exactly. So the other myth, can I just clarify about injection? You don't need to. It's a joint.
Yeah.
So if you put a needle there, it goes around everywhere.
It makes sense. Yeah.
But the key thing is, look, what you're saying, absolutely, Chris, is great. Look, the steroid reduces inflammation. Now, it doesn't cure the ligament.
No.
It doesn't remove the thick tissue, but it shrinks it down.
Yeah.
Probably thins it out.
And sometimes they don't work enough to get them back to what they need to do.
And if they don't work enough, but they helped a little bit, and you say, actually, Sam, I gave this guy an injection and he got better, but after about 6 weeks, he says it hurts again. Yeah. It's fine. All I do in that scenario is I put a camera in the ankle, so-called arthroscopy, and I just shave the undersurface of the ligament, remove that tissue, so it's gone. And it's a very quick procedure, and because you're not really touching the cartilage, you're not touching the... They recover very...
There's not a lot of healing after, is there?
We all think that arthroscopy or keyhole surgery, we must be doing a lot. Sometimes we're doing a lot in an arthroscopy, loads of stuff. Sometimes we're just doing a little bit of stuff. But the recovery obviously varies. So it's an easy thing to fix. And then obviously the other causes of it, why might they still be sore? Then you've got the slightly rarer causes. So you've got things like cartilage damage, where you've actually cleaved off a bit of cartilage and caused something called an osteochondral defect. Now, I think if an MRI picks up an osteochondral defect, then that's something that should be referred. Because at least to give reassurance to the patient that
particularly if you're swelling up,
and is reacting to it. But again, if it doesn't react to it, then don't do anything about it. Crack on. You don't need, we don't need to worry about it. And the other one that I do want to kind of, they're the two commonest. There might be peroneal tendon tears.
As
the
well.
Peroneal tendon can tear. Usually you'll have had a bit of more background there of a few problems over the years. People with very high arch feet are more likely to tear peroneal tendon.
They can be trickier generally, can't they?
But I think what is worth us always looking out for, because this is our cohort that we look after, the footballer's ankle. Okay, which is a completely different beast.
Yes,
and it's a lovely beast because it's so nice and easy to treat. Okay.
Maybe physio-wise, you're sometimes limited with what you can do.
But surgery is the most of all the arthritis.
Do you want to talk through what a footballer's ankle?
Footballer's ankle. So if you imagine, what happens is we call it footballers in England. Americans are always politically more correct than us. They call it sports person's ankle.
Oh, okay.
But they can't call it footballer's ankle, can they? Because they don't play soccer.
Soccer ankle.
So they can't call it soccer ankle. But it happens in other sports.
So well.
So it happens a lot in rugby. It happens a lot in footballers. But I do see it in runners and I see it in hockey players and stuff as well. Okay.
I think particularly with football, because you're kicking on that point.
You're kicking on that point, you feel it. So what basically happens at the front of the ankle, you develop an additional rim of bone. So you develop a spike here, and then you develop a separate spike of bone on the front. Okay, or an osteophyte or a spur. Now, people call osteophyte, so they assume, Chris, that this is an arthritic joint. No. But it's not. It's not. It's a spur. It's
a bony spur.
But it's called an osteophyte. So sometimes the X-ray doctor will write to the GP saying this is an arthritic ankle. And I love those cases because I get these patients coming. They're quite relaxed about that. Oh, doc, how old are you, mate? I'm 22. What's your problem? I've got an arthritic ankle. I'm like, whoa, man, that's serious stuff. They go, no, I've got an arthritic ankle. And I'm like, you haven't got arthritis, it's got some spurs at the front. So you form it.
It's just an extra bit of bone.
It's extra bone. But the story is great there. So they can always play. Okay, they can always play football. It hurts the next day. It hurts for 2 or 3 days. And it stops hurting.
Then they play again. In the end,
they just grind. It takes them about a month. It takes about a year to realise there's something wrong. Because it hurts every time I play. But they can still play. And so that responds very well. So that, you guys, as you said, there's not much you can do because it's a bony thing. But we can just, keyholes, we can grind the spurs down. And
so what happens? You want to just show that when you've got the two bones, it basically gets impinged.
It impinges, yeah. It impinges. It catches
and the tissues
bones
around
catch,
it.
Tissues around and get angry and inflamed, and you just end up catching them. And it's very easy. You could just clear the front of the joint, and actually it makes the ankle better.
Yeah. I've done a few injections on them, and generally speaking, it helps for us. Like get them through the rest of the season.
Yeah, of course, because you can't. It's the kind of thing you do typically in June. When the football season's finished. You just do it then, and they're back.
Because the recovery's
and you'll see some of the elite, the professional footballers. They'll have the operation done twice in their life. In their career, every 4 or 5 years they're having it done just to remove those spurs.
Okay, cool. Well, that probably brings us to the end.
Okay.
I mean, if anybody has any questions around sort of recurrent ankle sprains, hopefully we've made you just think a little bit more about it. And sometimes it is worth getting somebody to look at it, particularly if you're rolling over a lot on it. Those recurrent ankle sprains that probably don't hurt that much every time you do it and you recover quite quickly. But what I think we're trying to get across is that can still damage the joint.
In a big way.
Yeah, and it's important to make sure. And sometimes we see people when they've got that instability, you do an MRI, and actually their joint doesn't look too bad.
Yeah, absolutely. And then they're great, you tighten their ligament. And sometimes you have people, and we must forget there's a group who just go over anyhow. You have some people who just either there's a group who just go over.
Well, that actually
the ligament's fine.
That links us into a group that probably we should mention is the hypermobile patient.
Hypermobile patient,
So patients that have quite a lot of flexibility throughout their whole body are quite prone to this. And certainly from a physio point of view, they are trickier to get better.
And they're hard. And they're also less successful from surgery as well.
So
unless you have the ankle is the only joint that's a bad one, they'll often not do that well from surgery. So we have to watch out for that. And they're the ones who often need the so-called functional instability. We call mechanical. We spoke earlier, Chris, was about when the ligaments are loose or the bone is
the whole thing's loose.
It's loose. The muscle might be torn, etc. But functional just means that they just can't. They just in a way.
They're not strong enough. The coordination's affected their proprioception.
They can't feel the uneven ground. And
you can retrain that.
Absolutely.
Probably to a certain extent. But then sometimes, they are, for want of a better term, too far gone.
Absolutely.
That you can't control it.
Exactly.
So hypermobiles can certainly be quite.
But the important take-home message is that remember that just because your MRI says your ligaments are damaged, does not mean they need repairing. Because the majority of patients
get better.
But
it's those loose ankles
that we're really interested.
Physios are great at getting stiff things moving. But it's very hard to tighten up a loose joint.
Absolutely.
That's where.
And I think I love it because your ankle comes out too loose. It comes out. It comes back to you a little bit stiff. It's fine.
But don't over tighten it.
No, we never do because we tighten it 110%, so it stretches out by 10% by the time it gets to you.
I'm sure.
They're all tissues.
I'm sure you're very good at what you do. So.
Cheers, Chris.
Excellent. Well, if you've got any questions, let us know. But thanks very much, Sam, for your time today. Enjoyed it.
Thanks a lot.
Thank you.